Okay, well, hello everyone, and welcome to the first Pediatric Assembly Journal Club of the new year. My name is Jane Taylor from UPMC Children's Hospital of Pittsburgh, and I will be moderating today with my co-moderators, Dr. Maria Tang Santiago from Cohen Children's Hospital, who's also one of our current web directors, and also two of our junior web committee members, Dr. Pooja Mishra and Dr. Aditi Zaveri, both from UPMC Children's Hospital of Pittsburgh. We will be discussing the article, Performance of the Pediatric Asthma Risk Score Across Diverse Populations, which was published in August of 2023 in the New England Journal of Medicine Evidence Journal. Dr. Joyce Biagini, one of the authors, will be presenting their work. This will be followed by a panel discussion with her co-author, Dr. Catherine Rivera-Spoljarek from Washington University in St. Louis. We also have Dr. Ann Coates from Barbara Bush Children's Hospital and Dr. Christina Galledo from UPMC Children's Hospital of Pittsburgh. Following that, there will be an open question session for participants, and questions could be entered in the chat feature at any time during the session. Dr. Zaveri and Mishra are going to be collecting the questions to ask. Also, at the end of the panelist discussion, you can raise your hand and be unmuted to ask your question directly to the panel and to Dr. Biagini. So without further ado, Dr. Biagini, I'll let you get started.
Thank you. Let me share my screen here. All right. Just trying to move the Zoom out of the way so you can see. Okay. Are you able to see the slides okay?
Yes.
Thank you.
Yes.
Okay, so thank you everyone for inviting me to present our research. I'm really excited to be here. I am presenting this on behalf of all of my co-authors from the writing group that we had with CREW. This was a very large undertaking that took a few years to finally come to fruition. But as Jane said, our article is called The Performance of the Pediatric Asthma Risk Score Across Diverse Populations. So Dr. Hershey and myself developed PARS back in 2018 as a quantitative personalized tool to predict asthma development in young children. And over on the left is the scoring sheet that we published with the article. You can see that it's based on 6 simple clinical and demographic factors that are across birth through age 3. And then we also have a website on the right-hand side, and you can see that we did update the text of the questions a little bit to be more user-friendly once we published our website. So the PARS score ranges from 0 to 14. They're defined as low, moderate, and high risk. So scores of 0 to 4 indicate 3 to 11% chance of asthma, 5 to 8 is moderate risk, 15 to 32%. And then high risk scores, anything above 9 is 40% and above chance of asthma development. Our website that I mentioned has been utilized thus far by over 35,000 unique users in 166 countries, and our app has been downloaded over 3,500 times on the App Store. PARS has also been awarded a quality mark from the Organization for the Review of Care and Health Apps. They review health apps for safety, security, and clinically assured apps, and they awarded us a score of 77, which gave us a quality mark. So when we originally developed PARS, we developed and validated it in a very relatively homogeneous populations. So the Cincinnati Childhood Allergy and Air Pollution Study is a birth cohort that started in 2001 in Cincinnati, and it reflects the demographics of the general population of the greater Cincinnati area. So we had about 23% self-reported Black individuals. And then our validation population was from the Isle of Wight population birth cohort study, and that population was over 90% white. So this project really came out of our need to validate our PARS model in a more heterogeneous and diverse population so that we could have more generalizability across the United States for usage of our tool. So we are one site that is part of the Children's Respiratory Environmental Work Group. It's a consortium of cohorts that were designed to study asthma across the United States. And it includes 13 cohorts that capture much more racial, ethnic, and temporal diversity than the CAPS population in the Isle of Wight that we originally developed PARS in. 9 of those cohorts we were able to use to validate our study. CAPS is included in this, so some of the analyses we excluded CAPS since it was the discovery population. The other cohorts were just too young at the time to be able to have an objective diagnosis of asthma or even physician diagnosis of asthma. And then in addition, we compared PARS to the asthma predictive index across all the CRU cohorts. So this just shows the geography of the cohorts that we included in CRU. It's the blue markers. I marked out the 2 that are not included, and then CRU also includes a birth cohort that was also not included, that's not on this map. But this just shows that it does span quite a bit of the United States. So when we define the PARS factors across the cohorts, these were the definitions that we used. So parental asthma was an ever report of the parent saying that they were diagnosed by a physician with asthma. For the child, for eczema, it was just a parental report of a history of diagnosis anytime between birth and age 3. The early wheeze factor was parental report of any wheeze at all between birth and age 3. And then we also assess for wheeze without a cold, which is again based on parental report, birth to age 3. For polysensitization, in the original PARS model, we used skin prick testing, but in the CRU cohorts, not all of them have skin prick testing, and some had specific IgE. So we did use both, and I'll talk about this a little bit more in the results. But polysensitization was defined as 2 or more positive and/or error allergen tests. And then the race is also included in the PARS model, and this is also a parental report. And these categories are collapsed down to either Black or non-Black. We had a couple different asthma definitions that we used in this paper. CRU previously published 4 asthma definitions that were harmonized across all the CRU cohorts, because if you can imagine, if 13 different cohorts and all the questions ranging from cohorts that started back in the 80s versus those that started in the 2000s, there was a lot of different ways to define asthma. So we used a definition that included a parent report of physician diagnosis with an addition of a parent report of greater than 1 wheezing episode in the past 12 months. And this definition was selected so that we could attempt to exclude children that had transient wheeze. 4 of the cohorts had either bronchial hyperresponsiveness reversibility testing or methylcholine challenge testing. And so we also looked at an objective definition of asthma that included those objective lung function measures in 4 of the 10 cohorts. So this table is from the paper. It's the demographics of the cohort. I just want to call your attention to the overall demographics in the red box. So we had 5,634 children across the cohorts that were included, and that included 23% that self-identified or parental report identified as Black or African American. We also had 16% Hispanics. They were very much matched for sex. And then down here at the bottom in the second red box, these are the PARS factors. And I want to point your attention to a couple of things. First of all, the factors varied widely across the cohorts. So if you look at the first one, parental asthma, it has a range from 13.5% up to 66%, depending on which cohort we looked at. There were also many cohorts that had missing factors. So if you look across to essentially the missing boxes, a lot of cohorts didn't collect wheeze without a cold, and not all of them had polysensitization. So first we looked at the overall performance of PARS across the CRU cohorts. We calculated the area under the curve. We also compared that to the area under the curve when we applied the API model to the different cohorts. So our AUCs for PARS ranged from 0.61 to 0.83, with an overall harmonized AUC of 0.76, which was higher than the harmonized AUC for the API, which was 0.7. So We originally published that PARS had a higher performance than the API and CAPS, and we saw the same effect when we looked across the additional 9 CRU cohorts. So we also had our sub-analysis with the asthma definition that included objective measures. And when the objective measures are used, the AUC was 0.78, again, compared to 0.7 for the API. So it was, again, superior in predicting asthma compared to the API. We also evaluated the sensitivity, specificity, and the positive and negative predictive values across all the cohorts. And the median sensitivity and negative predictive values remained similar to the original CAPS cohort, but we did see slight decreases in specificity and positive predictive value. So the next thing we did was to stratify the analyses across these variables of diversity that we were interested to see how the PARS model performed. And so when we looked at Hispanic ethnicity, sex, and the type of cohort, so some of the cohorts in CRU were recruited to be reflective of the general population, but some were recruited to have a higher parental history of asthma and allergies. And so when we look at these 3 things, we see that the cohorts don't differ. They perform equally well across ethnicity, sex, and cohort type. I also mentioned in the demographic slide that our some of the PARS cohorts had missing data. And when we looked to see the cohorts that had missing data versus those that had complete data, again, there was no difference in the performance of PARS between the two sets of cohorts. So the original PARS used SPT to find polysensitization. And like I said before, not all of the cohorts had skin prick testing. So we compared the overall AUC between cohorts that had skin prick tests versus specific IgE. And then in the 4 cohorts that had both, we directly compared the performance of PARS with SPT versus IgE. So up on top, you can see the AUCs of the cohorts that had SPT versus IgE. And again, there was no significant difference between the model performance there. Down on the bottom in the table, if you look at the AUCs within each cohort, they are almost identical, whether SPT or SIgE are used. And in some of those cohorts, the number of allergens are different. And I think, yeah, that's brings me to the next slide. So the allergen panels that were used by each cohort varied widely. The range was from 4 to 17 allergens with a median of 8.5. So we wanted to make sure that polysensitization wasn't driven by the number of tests. And so we looked at the number of the cohorts that had either above or below the median number of cohorts and compared the AUCs. And again, there was no difference in model performance. So the original PARS model was built with a logistic regression model with the odds ratios being converted to scores that were used then to add up to your PARS score. And so we wanted to look at the odds ratios across the 6 factors across all the cohorts. And you can see from these 6 panels that the odds ratios showed significant variability across the 10 cohorts for all 6 PARS factors. However, when we did a meta-analysis of all the cohorts across CRU, we saw that 4 of the factors remained with the same weight from the original model: parental asthma, eczema, wheeze without a cold, and polysensitization remain with the same score. We did see early wheeze increased by 1 point and black race decreased by 1 point, but the maximum score remained at 14. And the weights generated from this meta-analysis score produced an AUC of 0.76, which is identical to the original PARS AUC. So this shows that our original weighting of the factors to be valid. So I also mentioned that we compared PARS to the Asthma Predictive Index. And so this graph shows for each PARS score, the prevalence of asthma, and the gray shading shows the number of participants that are also detected by the API. So you can see in scores 9 and above, the shading is almost full in those bars, and that reflects that we had 99% of children detected by the API that had a PARS score of 9+, which is high risk. On the lower end, The API identified 93% of the children with a score of 2 to 4 as being non-asthma. But in the middle, the scores that have the moderate risk between scores of 5 and 6, the API does miss 31% of asthmatics in that range. So in summary, the PARS is a robust to vast heterogeneity, missing data, and dissimilar capture of risk factors, which really underscores its validity and robustness across these diverse populations. It performed equally well using 2 definitions of asthma, one using objective lung function measures, which highlights the ability to predict asthma even when lung function isn't available. And then it performs superiorly to the API for children, specifically for those with moderate asthma risk. And I just have a few key points that I wanted to touch on here. So no previous asthma prediction models that have been developed thus far have been developed in populations with substantial heterogeneity, but CREW enabled us to evaluate over 5,000 children, and that included 1,279 African American and 924 Hispanic children. And then race is one of the factors that is included in the original PARS model. Previous CREW research has revealed a higher asthma risk for Black and Hispanic children, even after controlling for socioeconomic factors, indicating that race is not a simple proxy for socioeconomic status. Race is likely a proxy for overlapping determinants of health, including structural, institutional, cultural, a myriad of factors. And we acknowledge that the use of race in PARS may unintentionally perpetuate structural racism. And we actually right now we are working to replace the race variable in PARS. I will say we had another publication where we did attempt to include other factors into PARS, and we couldn't replace race. We acknowledge that race itself is not a biologic predictor of asthma, but we're trying to find what is encompassed in this one variable that we can use to replace in the PARS model to take race out of the PARS model. So for polysensitization, it was robust even when we used skin prick test or IgE. And it was independent of the number and types of allergens tested. This is important in research, as you can see there's no standard that exists for sensitization testing. It's a range of just what allergens are available or what's pertinent in your area. So the added utility of PARS really to the asthma research field is that it can predict asthma across mild, moderate, and high risk. And for research purposes, our PARS model can be used to risk stratify participants for intervention studies, and then efficacy can be evaluated across the risk spectrum versus the API, which when used to populate intervention trials, it pulls in those that are all at high risk, which may already have too many risk factors to be able to intervene. So I do want to acknowledge the PARS writing group members. Like I said, this was a village undertaking for this project. And so I have everyone listed here, as well as some of the folks that helped us with access to the data from CREW. And then, of course, the participating children and families in all of the 10 cohorts. And then we were funded by the CREW Consortium, which was funded by the NIH Office of the Director and NIAID. And I did want to include the website, just in case anyone was interested in checking it out. The QR code will link directly to the PARS website. So with that, I will stop and turn it back over to the moderator.
Dr. Biagini, that was wonderful. Thank you for sharing your expertise with us. At this point, we will transition to the panelists, and we have with us today Dr. Catherine Rivera-Spoljaric, who's a co-author, also Dr. Ann Coates and Dr. Christina Gallardo. So we'll let you guys ask some questions and bring up some pertinent topics, and then open it up later to the audience to answer and ask questions. Be sure to put questions in the chat if you don't want to actually virtually raise your hand and get called on later, or if you want to ask in person, that also is fine. After our panelists are done discussing, we will open it up and you can just virtually raise your hand, and then us moderators will call on you. Okay, let's get started.
Okay, I'll go first. Um, Jocelyn, I mean, you did a great job presenting, wonderful job presenting this. I think this is a big
Thanks.
undertaking, and it's great data to have. Um, I did want to talk about the usefulness, like clinical usefulness of an asthma risk score. You mentioned, you know, the usefulness in research that we can uh, appropriately maybe identify those patients that are more at higher risk for trials that aim at maybe asthma prevention, and interventions for treatment or to initiate treatment. What do you see that also as one of the clinical usefulness? I think one of the usefulness that I see for asthma risk scores in just day-to-day clinic and in the hospital is, answering questions from very concerned parents that that want to know what is the risk of their child to develop asthma in the future. And I've used this score actually to sometimes answer that question, or it's not perfect, but to shed some light on what I think will happen. And then also to have a little bit more of a guided approach to initiate therapy on children. So have you had that discussion, maybe also from my other panelists, in terms of like the clinical usefulness of a risk score?
Yes, we did design this also with clinical usage in mind, and also for families themselves to be able to access the website, like you said, because they have a concern, they have a family history, and they want to know what is the likelihood that their child is going to go on to develop asthma. And the great, thing about PARS is that it gives a range of risk. It's not just a yes, no. And so, the model returns a much more personalized risk score than compared, to something like the API. And I definitely think, I'm not a clinician, but I do, think that this can be used to personalize treatment for the child based on their known set of risk factors.
Yeah.
And go ahead.
No, go ahead.
No, I was just going to say, I know that we do utilize this in our EPIC system in children's. It is available. I'm not sure about other institutions. I would love to see it, rolled out though in other medical charts to be able to use.
Yeah. And I have one more follow-up question before I stop talking, so all people can talk. But I thank you for talking about race. It's always concerning that to some people that mentioning race is something that kind of enforces race as a biological construct as opposed to a social construct. So I think it's great that you're looking further into that and looking at other determinants of health to add there to perhaps eliminate race. I am wondering what's in the future for PARS. Maybe genetics?
Yes, we've talked about looking at, genetic data, transcriptomic data. We have evaluated some environmental exposures, but also evaluating, more environmental exposures as well. We're looking right now at measures of socioeconomic deprivation in order to try to eliminate the race and factor in PARS. And those measures are census level area based like constructs. So they capture environmental exposures at the same time as capturing, demographics and socioeconomics. So I'm not expecting that we're going to be able to say that these deprivation indices perform better than race, but I would like to see them perform as well. And so that we can use these measures because they're easily calculated if you enter a child's address, their home address. And so that's the direction that we're going immediately with PARS, but yes, again, with additional genetics and transcriptomics as well.
I can jump in here. I just first want to say thanks for inviting me here today to discuss this great work tackling the extreme challenge of trying to predict which toddlers are going to go on to develop asthma. And I just want to applaud you and your colleagues for this really important work.
Thank you.
Yeah, of course. And like you said, there are multiple asthma prediction tools out there, but none of them were developed most of them were developed primarily in white European populations. And like you said, this is really unfortunate because children who identify as Black, Puerto Rican, or American Indian, Alaska Native suffer from a much higher asthma incidence than the general pediatric population. And that's some of what my research is focused on. But because of this, it's unclear if results from studies conducted in non-representative samples are generalizable to the population of children who are most affected by asthma. So I just want to say kudos to you and your team for testing PARS in multiple diverse cohorts of children. And I think this is a really important step that raises the bar and challenges other researchers to include more representative populations in their asthma studies. That being said, I'm also really pleased to hear that you're working to replace race in PARS. Like you said, race is merely a social construct and not a biological variable. So while I have the PARS app on my phone that I use sometimes, I personally struggle a little bit with utilizing a prediction tool that explicitly includes race as a variable. And it's not just asthma that uses race in prediction models. Like there's prediction models for urinary tract infection in kids that also include race. But there was a study recently out of Pittsburgh, actually, that showed that in UTI prediction models, race can be replaced by other variables without affecting the prediction accuracy. So I'm hoping that you and your team will also be able to replace race effectively in the models. And I saw about a year ago, there was a study out of another great paper out of Cincinnati Children's that was published in JACI. And they looked at racial disparities in pediatric asthma ED visits using individual and neighborhood level risk factors.
Mm-hmm.
And so they looked at asthma-related ED visits in over 30,000 children, and they found that Black children had more ED visits than white children. But after they accounted for mediators like type of health insurance, area level deprivation, like you mentioned, and then neighborhood levels of PM 2.5 and outdoor mold, the association between ED visits and race was no longer significant. So I wonder if there's like an opportunity for collaboration with that group at Cincinnati to maybe try to identify some of those factors that, of course, asthma-related ED visits and asthma incidents are different, but maybe there's some overlap there that you could look into. So
yeah. No, I'm familiar with the paper that you're talking about, and one of our collaborators from the Division of Biostats and Epidemiology, Cole Brokamp, is the developer of one of the deprivation indices, the Maternal Community Deprivation Index, and I believe they used his index in that paper, and that we are working with Cole to calculate the MCDI across our cohorts as well. So yes, we are definitely working together to try to essentially get rid of race in PARS. That's our new goal.
That's great.
Good afternoon. I really want to echo what my colleagues, Dr. Rivera, Speljarek, and Gallardo have already said, that this is such tremendous work. Thank you so much for the opportunity to be a panelist today and to hear your presentation, which was fantastic, and learn more about this important work that's applicable for all of us, particularly it feels like no more so than at this time of year. And like similar to what Dr. Rivera Speljarek was saying, I think in understanding how best to manage and treat our patients, as well as educate and guide families and guardians on optimal treatment, our patients having a predictive risk score to be able to point to is incredibly informative, especially when it's come to, I feel, hesitancy on inhaled corticosteroid use. But I trained with the API. That's what I learned with. That's what I've always, felt most comfortable with. And so I was, interested to read on the superior performance for the PARS compared to the API and moderate risk population. Why do you think that is?
Well, the factors that are included in the API that determine that you have essentially a high risk of asthma, I think, are the more, I guess, the greater risk factors. And so children that are assessed as positive for the API are the high risk kid. It's not designed to be able to detect moderate risk. With children that have a lower number of risk factors, they may not have a family history, they may not even be sensitized, but they're showing, wheezing without cold throughout their toddlerhood. And so these are the children, I think, that the API are missing, that may go on to develop I don't want to call it non-state, but not these high risk phenotype that's detected by the API.
Great. Thank you. And then just my second question, and I may have misunderstood, and it looked like there was also a comment in the chat or a question in the chat about this, is how were you able to exclude transient wheezers based on your definition?
So it definitely isn't 100%. It's not a fail-safe exclusion. We just asked, so our first definition of asthma was just parent level or parent report of physician diagnosis. And to try to decrease the potential for transient wheezers in that group, we added the addition of having wheeze in the last year, but that certainly doesn't exclude, that's all of them that could be transient wheezers, which is why we also did the sub-analysis with the 4 cohorts that had the lung function measures available, that were very objectively diagnosed, and it showed very similar performance. So I know that there is definitely likelihood that we still captured some transient wheezing kids in that definition, but it's still, the model still performs quite well compared to the much more stricter definition.
Okay, thank you.
Well, I would like to thank our panelists again. That was an excellent discussion. Now we have Doctors Pooja Mishra and Aditi Zaveri that are going to ask some questions from the group. And then also, after we're done with that, if anyone wants to raise their virtual hand, we'll also be calling on you and you can ask your questions directly. Okay, Dr. Mishra and Zaveri, I'll let you get started.
All right, I'm Dr. Zaveri, and I can get started with the first question that we have, which is from Dr. Venkatesh Chandrasekaran. Dr. Coates already did ask his first question, which was pertaining to how transient wheezers were excluded. So thank you for answering that, Dr. Biagini. But our second question from him is asking how PARS can be made race neutral, which I know you've already touched upon, but more specifically so that it can be validated in populations outside of the US.
That is a great question. Really, it's, the access to the data sets, the cohorts are primarily European and American based. I agree that is definitely a necessity, but the availability of the data sets for us to be able to validate outside of the country, not including obviously the European cohorts that are mostly of white descendants. So I think we're really just trying to focus on removing the race component and trying to make it more applicable in that way.
Thank you so much for that answer. Pooja, I think you have another question.
And guys, I don't think we can hear Dr. Mishra.
Hi, sorry. So the next question is from Dr. Ata Avora, who talks about how this is a great presentation and thanks you for it. He also asked if you could comment on the possibility that the predictive performance of PARS is different for different ages, and does the frequency, timing, and intensity of the features, like wheezing, impact predictive performance? Because we know majority of wheezing or even asthma diagnosis less than 4 is transient. So he has 2 questions from that. One, which is, were early diagnoses, that is those under 3 years, omitted from the analysis? And then 2, does including these early diagnoses change the PARS performance?
So we haven't looked at the performance of the model with predictors over the age of 3. The reason for that being that it would then not necessarily be a predictive model. It might then just be a confirmation of asthma, and we wanted to keep PARS as a predicting risk of asthma, looking at those younger ages. But that is why we in our analysis tried to restrict those transient wheezers out of the asthma definitions and looked at those objective definitions of asthma. But again, that being said, there's definitely the possibility that these are transient wheezers that we're detecting and that they won't necessarily go on to develop asthma. So.
Thank you for answering that question.
I think that's also interesting because I think it underscores the utility of reapplying this questionnaire at different ages and stages on the same patient. We have one other question from Dr. William Hardy, who also thanks you for your presentation, but specifically wanted to ask about the utility of allergen skin testing. He states that many of their asthma patients do not undergo skin testing, but tend to receive blood testing panels such as IgE RAST panels, and would like to know if that's a suitable substitute in your survey or in your questionnaire for skin testing.
Yeah, and I don't have my slides up anymore, but we did actually compare directly skin prick testing to specific IgE in PARS, knowing because even in the cohorts across CREW that we evaluated, they didn't all have skin prick testing available. Some only had IgE, and some didn't have polysensitization data at all. They didn't do any skin testing. So what we showed is that IgE performs just as well as skin prick testing when defining polysensitization. But what we've also shown is that there's no significant difference in model performance, even if sensitization data isn't available.
I guess I have one follow-up question about that.
Sure.
Research studies sometimes use a different cutoff for specific IgEs. Like usually the threshold is 0, like greater than or equal to 0.35. Sometimes studies use a threshold of greater than or equal to 0.7. And I know you were using a multitude of different cohorts, but did any of the cohorts look at different levels of specific IgEs?
We harmonized the IgE data using a cutoff of 0.35 across all the cohorts, regardless of what the cohorts defined as positive within their own data.
That makes sense. Thanks.
Mm-hmm.
And then we had another question in the chat. Dr. Teresa Lamonica talked about, as not all kids with asthma wheeze, there's some recurrent frequent cough when in distress, which have different, distress from different triggers, and just especially in the children who have viral infections. She wanted to ask a little bit about clarification for those children.
Yeah, that's a good point, and one that we have not yet addressed in PARS. Certainly, the non-wheezing children that are having more of the night cough is something that we can again add to our model when we're looking at these other factors like environmental exposures and deprivation. So there's still a lot of work that we have to do, but that's an excellent point of something that we can evaluate and as we continue to try to refine our model.
And then there's also a couple of comments in the chat. There's one from Dr. Stefania Cormier, who's thanking you for the great work. So I just want to ensure that we're letting you know about how much
thank you,
how much everyone appreciates you discussing this with us.
Thank you so much.
Jocelyn, I also wanted to add the cough one is difficult because not all the birth cohorts ask that question.
True.
So, in knowing all these birth cohorts and having dealt with some of this data, that's a very tricky question. So even though yes, I agree that is something that's important to look at, I'm not sure that the design of any of these cohorts includes fine-tuning questions that address specific cough and that asks enough detail for us to analyze that variable very well. So that's something like that we should take into account when we are designing birth cohort trials now moving forward.
Yeah, that's an excellent point. I mean, you know firsthand how much we struggled with harmonizing just these 6 factors across all these cohorts, and definitely some of the cohort. I know obviously CAP's much better than all the other ones. A lot of the cohorts did include the Isaac questions, which was nice in defining the wheezing phenotypes. And I think there is one on night cough, but again, a lot of the older ones didn't include that. And so as we dive into that data, I'm guessing that there will be a lot that just have missing data. Like you stated, the questions just weren't asked. So yeah, for the future, I think it is definitely important to try to look back and see what data has been reported and take into consideration whether or not, if you want to compare to what's been shown, you have to collect those factors, you know, in the future studies.
Well, I think now we can open it up. If anyone wants to ask a question directly, you can virtually raise your hand and Dr. Santiago will call on you and let you know you can unmute yourself.
And while we're doing that, I think Dr. Ann Coates had one question about nocturnal cough.
Less of a question, but more something for the future as another factor to include in the 6 that you've already included.
Aditi, there's a question from
I see, yeah, I see
Dr. Afolabi.
Right. I see a question from Dr. Afolabi, who wanted to ask you whether practically you think the PARS questionnaire can lead to an overestimation of asthma in Black children.
So we didn't publish this. We did look at the performance of PARS with those that self-identify with Black and white, and there was not a difference in the model performance. I think that it's a hard question to answer because we know that Black race isn't telling us any biologic information about the child. So it's really hard to say but it is measuring something in some children. And I think that maybe, we're even missing some of these factors, and maybe it's children that identify as non-Black that have this set of risk factors that we have yet to define. But we know that this little, set of risk factors make you much more likely to develop asthma. And so I think that, that's again, the biggest reason that we need to get away from race and away from, racist research really, and look at, where the children are living and the demographics and the exposures in this area and see what is promoting asthma development.
Thank you for that. And I think Dr. Gallardo has shared the PMID for the Cincinnati study that did look at geographic and other factors that's something about racial disparities in pediatric ER visits for anybody interested in it.
I don't see anybody raising their hand, Jane. I just wanted to
I do see a question by Dr. Collins.
Okay, go ahead.
Yeah, I couldn't figure out how to raise my hand for some reason on this laptop, so I apologize. My question is, and I have to tell you, this asthma risk score is something that I haven't given a lot of thought to. Like Dr. Coates, I'm more familiar with the API, but what really plagues me in this young child group is recurrent infections. And I see those being different if we're thinking about exposures rather than your race and ethnicity. If you live in a different country, your exposures could be very different. You could have more exposures to bacteria, you could have more exposures to parasites, or in the US, the big question I always get asked about is RSV. So how do you think infectious, being that broad term of not just RSV, how do you think we could capture those kind of risk factors and incorporate that into our kind of anticipatory guidance for our patients and families?
Yeah, that is a great question, and one that we haven't, gone down that road in PARS because of the problems. As we can do it for the US, the most common infections, just looking at upper and lower respiratory. We've looked around with our data, looking at the number of respiratory infections in the first year. Is there a threshold that makes you more likely to develop asthma? But you're absolutely correct that even exposures to air pollution are vastly different around the world. We're very good now. I don't say we. There's a whole other group of people that is not me, but that use satellite data and looking at particles in the air, and are able to really hone in on an individual's just overall outdoor air pollution level in the US. But these models aren't available worldwide, and so it is difficult for us to be able to have exposures, like you're saying, even if it's viral or air pollution, that are all encompassing of the globe, essentially. And even with our race variable, trying to use the deprivation indices to replace that in PARS, I think these models are still only available for the US. And so it does make the worldwide utility difficult. And the only, thus far, race is unfortunately the only variable that is applicable worldwide. And so that is, that's what we started with, and we couldn't replace it. We tried all the exposures we had here. But yeah, it's a difficulty in being able to capture all of those factors, in all of these different countries. So it's a great point that I unfortunately right now do not have the answer to.
That's okay. If we had all the answers, we wouldn't have any more research questions, right?
Yeah, right.
Well, it's been a great discussion so far. Are there any other questions before we wrap up?
Jane, while we're waiting for people to put in any last questions, I just want to remind everyone that this is recorded, so it will be on the ATS webpage in a couple of days, right, Jane? Usually,
correct. It usually takes about 3 to 4 days.
Yeah. And so you can tell your colleagues who weren't able to come that they can definitely, see the presentation.
Dr. Zaveri, Dr. Mishra, are there any further questions or any hands that are raised?
We were just wondering if Dr. Avora had any other questions. I think he raised his hand in between.
Sure. Just a follow-up question. Again, thanks for answering the previous questions. I was just wondering from a sort of a practical point of view, if a child, for example, showed up, at point of care and were 5 years old, and you quickly run the PAS, how well would it perform for that child who's 5 years old? Let's say another child shows up and they were 6 years old. How well would the PAS perform for that 6-year-old child? And the reason for the question is, I'm just imagining the changing circumstances, both physiologically for the child, but also potentially environment and some of the other factors that some of the other panelists have mentioned. How would that sort of impact sort of this growing child, and how the PAS sort of helps us recognize if it's a problem that warrants a further investigation or not?
Yeah, that's a good point. And I think, one that Catherine had touched on earlier, that, PARS is something that could be used continuously to monitor the child's asthma risk as they grow. In the children in this analysis, the asthma outcome was assessed anywhere between 5 and 10 years of age. So we didn't look at individual ages. We looked across the whole cohort. But that is something that we could look at to see, is it 5, 6 versus 7, 8, or 9, 10? If the utility does change, that's something that we could do. So I thank you for pointing that out. I appreciate that.
Okay, any last questions before we end? Well, if not, this was a wonderful way to start off the year. Thank you again. I would like to thank Dr. Jocelyn Biagini for sharing her expertise with us. Also a panelist, the co-author, Dr. Catherine Rivera-Spoljaric, Dr. Christina Gallardo, and Ann Coates. It was a fantastic discussion, and all of you as well, because all of the questions are what just enrich the discussion that much more. So thank you for participating. And with that, I would like to thank my moderators, Tang Santiago, Aditi Zaveri, and Pooja Mishra. And we will let you know when another journal club is going to come out. It'll be a few more months, but we have some in the works. And again, this was a fantastic one to start off the year. So you started it off right. Thank you again, guys.
Thank you so much for inviting me. I'm very honored to be able to present our work.
Thank you for coming and sharing it with the rest of the assembly. It's very appreciated. Truly appreciated.
You did a
Happy New Year.
fantastic job.
Thank you. And if anybody has any follow-up questions, feel free to reach out and email me.
We'll definitely
you,
let you know if we hear of any questions. That's
Sure.
okay. Thank you so much.
You've raised the bar. You set it really high. Great job.
Thank you.
Absolutely. And with that, everyone have a great rest of your afternoon. Thank you for joining us.
Thank you. Bye, everybody.
Thanks. Bye.
Bye.